right, now I think we're good. All right, so celiac artery aneurysms. Very, very rare entity. There's a couple of case reports in the literature about treating these. People have talked about using stent grafts and transcatheter coil embolization. I personally think that's making it even too complicated, and I'm just going to show using transcatheter embolization coils to treat this. This is a large dissecting aneurysm. I think anybody who does imaging will probably see this entity in their practice not terribly infrequently. This patient likely has a connective tissue disorder, as you can tell by the superior mesenteric artery being so distorted. But here's a diagnostic angiogram, and I do all my transcatheter coil embolizations through a guide cath. So here you have a nice reverse curve guide cath from a femoral artery approach. Here's the lateral angiogram. You see this very, very large, ugly dissecting aneurysm involving the celiac artery. And basically, the principle here is you want to essentially perform an endovascular surgical ligation. So you need to get into the splenic artery and a coil occlude it, the common hepatic artery, coil occlude it, the left gastric artery, coil occlude it. And again, you can start to see here, we're starting to fill up all the different branches. And as you keep on going with the coil mass, you get into every single branch, obviously, and start to fill it up. This case took about 25 coils. And you can see on the final injection of the superior mesenteric artery through the existing collateral pathways, you're still perfusing the entire liver and the entire spleen. People say, aren't you concerned about end organ infarct, end organ injury? So here's the follow-up study, and we always get MRIs on these cases because the coils are actually transparent on MRI. You can see the liver is completely normal, and the spleen is completely normal. There's no organ infarct whatsoever, and I think that's an example of a very, very good use of transcatheter coil embolization to preserve the end organs and obviously treat the aneurysm. Here's a subtle variation on this. This is a celiac aneurysm coming off a celiaco-mesenteric trunk. This is probably a case report about how rare this is. But this case we did transradial, and again we have a guide cath coming down from the wrist, and here we're injecting the celiaco-mesenteric trunk, and you see the obvious very large aneurysm involving the celiac artery origin, and then again the splenic artery, the celiac artery, sorry, the common hepatic artery and the superior mesenteric artery. Here we did stent-assisted coiling, so we actually had a safety wire down the SMA, put a balloon expandable stent across the origin of the celiac artery and the celiaco-mesenteric trunk, coiled all the outfurrow branches. Here you can see the microcatheter going through the interstices of the stent again, and then filling up the entire mass with even more coils. This took about 30 coils, but again was done under conscious anesthesia. And then here's the final angiogram, and you can see again the celiac artery is filling through collaterals. The aneurysm has no perfusion to it whatsoever. And again, there's the flush aortogram, and on the follow-up MRI, again, there's no splenic infarct, there's no hepatic infarct. All the abdominal organs are perfused. This patient went home the next morning, no abdominal pain. The SMA, you can actually see here on the lower right, lower left picture here, the SMA is wide open, the stent is invisible. So again, a very, very nice treatment for that rare entity. Hepatic artery aneurysms, again, very, very rare, but sometimes you see them and they're very, very complicated to treat in terms of how you're going to preserve the perfusion to the liver in this circumstance. Here's a case of a liver transplant with a pseudoaneurysm coming off the hepatic artery graft. And if there's any case that you cannot lose the hepatic artery, it's in a liver transplant patient. So this actually looked like it was going to be very, very challenging to treat, but we actually used the similar techniques of the case I just showed you before with the stent-assisted coiling, and this worked out, again, very, very nicely. So here we're trading out from a selective catheter through a reverse curve guide cath. We have a wire across the neck of the aneurysm into the right hepatic artery. We actually put a coronary stent across the neck of the aneurysm to preserve perfusion to the remainder of the liver. And there's the stent deployed, and then a microcatheter through the interstices of the stent, filled up the aneurysm here with detachable coils, and very, very nice result. And again, the perfusion to this organ transplant was actually preserved, and the patient did very, very well with no issues of bleeding or aneurysm expansion afterwards, and just the final angiogram there. Here's an arterial portal fistula. This is a very, very rare case, but it's a nice example of having a patient avoid surgery. This was a woman just on a routine physical exam with her gynecologist, was found to have a pansystolic murmur, obviously a very, very good physical examination from this primary care doctor, and it immediately sent the patient for a CT angiogram and found this, which everybody was like, oh my God, what is this? Because I certainly hadn't seen this before. Very, very interesting, rare case. And as best as we can tell, this young lady likely ruptured a hepatic artery aneurysm during her previous pregnancy without even knowing it, and developed this large arterial portal fistula. And so we had, multiple, team-based conferences on how to treat this. Options including surgical resection were involved. She was objectively asymptomatic, but she actually had hepatomegaly and splenomegaly, and was likely going to develop symptoms of portal hypertension very soon. And so most people felt that she could not be left alone. And so here on catheterization, you see this very, very large pseudoaneurysm in the left lobe of the liver here. And I'll just go straight out to the case here. We actually were able to get a guide cath. That's a diagnostic catheter, but all the way out into the left hepatic artery. Here, just interestingly enough, the superior mesenteric angiogram, when the portal vein fills, only the right side of the liver is filling on the portal vein, because the left side of the liver is being perfused by the fistula. There's the portal vein run going up, filling up the right lobe. And so again, we decided to treat this. There's a guide sheath and a guide catheter well into the left hepatic artery. And in this case, instead of using coils, we decided to use Amplatzer plugs. And we put several of them in. This was able to be performed through a 6 French system. And so this is a 6 French guide, and the Amplatzer 1s being used to fill up the left hepatic artery here. And just a cine of it being detached from the introducer pusher wire. And here's the completion angiogram, and you'll notice that there's actually preservation of the native hepatic arteries, which are normal there, but the fistula has been completely occluded. And here's the completion celiac angiogram, and now you can see the remainder of the liver being perfused completely normally, and again, the fistula has been completely shut down. And then the final SMA run, which is going to now show perfusion to not only the right portal vein in the right lobe of the liver, but the left portal vein as well, and the left lobe of the liver, which is where you see right there. This patient we actually have long-term follow-up on, and so she came in for a follow-up CAT scan just a few months ago. And you can see that the fistula is completely sealed up. The liver has returned to normal size. The spleen is normal now. And again, here's the reconstruction showing that the entire hepatic artery is reduced to normal size, and you obviously see the Amplatzer plugs there. So just a couple of interesting cases on the use of transcatheter coil embolization to treat complex vascular lesions. Thank you very much for your attention.